So, warm greetings, everyone. Good morning, good afternoon, good evening, wherever you are. Thank you for joining us for this International Men's Day webinar that's being organized by the World Health Organization, Global Tuberculosis Program, and the International Union Against TB and Lung Disease, the Union Working Group on Gender Equity in TB. The theme of today's webinar is multi-sectoral engagement to improve gender equity in TB and to ensure no one is left behind. Thank you so much for joining us. We have an excellent lineup of speakers to put the spotlight on how this disease that remains on one of the top infectious killers affects men, and the steps and solutions that we can take to leverage for a gender sensitive TB response. I'm Monica Diaz from the Global Tuberculosis Program at the World Health Organization, and I'm very pleased to be here with all the speakers. Today, I'll go through them one by one as we go through the session. But to open this webinar, I'm very pleased to call upon Dr. Teresa Kasaeva, Director of the World Health Organization Global Tuberculosis Program, to deliver opening remarks. Teresa, over to you, please.
Thank you very much, Monica. Dear colleagues, partners, and friends, welcome and thank you for joining this important webinar on the occasion of International Men's Day. We as WHO are very pleased to co-host it together with the International Union Against Tuberculosis and Lung Diseases, a working group on gender equity in TB. As you've heard, the theme of the event is multi-sectoral engagement to improve gender equity in TB to ensure no one is left behind. And first, of course, I would like to wish you the best in this International Men's Day to all men in the audience. The focus is on you, but not only, of course. We are covering all the aspects of TB, and women, children are also among vulnerable population. But as data shows that TB definitely affects men. Now, we have the opportunity to focus on one of the top infectious killer on the world, tuberculosis. This disease respects, as I've told, no gender, age, or boundaries. It affects all, especially the most vulnerable and poorest. We are placing the spotlight on TB in men today to mark this day, and not only, but as you are following our events, we are putting also focus on women during the International Women's Day, on children and other vulnerable groups. These TB webinars give us opportunity to do a deep dive on critical issues or on groups of people affected. As we highlighted in the Global TB report that was launched last month, the COVID-19 pandemic, coupled with the ongoing crises such as armed conflict, increasing food insecurity, political and economic instability, has reversed years of progress made in the fight against tuberculosis. For the first time in nearly 2 decades, WHO is reported an increase in the number of people falling ill with TB, and including drug-resistant TB, alongside a continued increase in TB deaths. Globally, an estimated 10.6 million people fell ill with the tuberculosis last year, with the men accounting for nearly 57% of those affected. Prevalence survey indicate even greater disparity in identifying burden of the disease. As we look at accelerating the TB response and getting back on track, we need to ensure gender considerations into our efforts. Gender is one of the important social determinants of health and should be a critical component of strategies to end the TB epidemic. Studies show that men's disadvantage in TB extends to diagnostic and treatment pathway, where men have limited access to timely diagnosis and treatment and higher risk of treatment failure and death. Most new infections among men, women, and children are likely attributable to contact with men, meaning that men's excess burden of disease and the devastations in prevention and care have population-wide implications. Dear colleagues, we have several objectives for our webinars today. First, to bring together TB communities affected by tuberculosis and their coalitions, women's and men's group, community-based organization, non-governmental organizations, and experts working on women's and men's health, policymakers, and program implementers to create a multi-sectoral conversation around developing a gender-sensitive response to NTB. Another objective is to explore opportunities through multi-sectoral engagement, how to improve gender equity in TB. Another aim is to widen understanding of gender inclusivity in the global response to end tuberculosis. Dear friends, we have a really impressive, great line-up of speakers today from the communities, countries, civil society, and partners. I would like once again to thank you very much for joining us today, and we are looking forward to meaningful deliberations and outcomes from this important webinar.
Thank you so much, Teresa, for those inspiring opening remarks and for setting the scene on this important topic as we commemorate International Men's Day. Thank you for that. So we'd now like to move to our next speaker, Stephen Anguva. He is a TB survivor, a passionate TB advocate, a member of Youth Network, WHO's 1+1 initiative, and he has his own TB survivor group in Kenya. So we're very happy to have with us Stephen Anguva from Kenya to share his personal perspective on this day, on International Men's Day, and also to share with us the work he's doing and how he's moved from being just a TB survivor to a TB champion. So Stephen, the floor is yours. Over to you, Stephen.
Thank you very much, Monica. Good morning, good afternoon, good evening, colleagues. And thank you very much, WHO family, for giving me this platform to talk to my fellow colleagues. When I was diagnosed with TB about a decade ago, I suffered stigma and discrimination from family, friends, and neighbors, which is something that I wouldn't want anybody, even my worst enemy, to go through. But after recovery, I was able to form an organization called Pamoja TB Group, which is a support group for people that are living or are affected with tuberculosis, where we come together and share experiences and support one another throughout the course of treatment. And this, we've done it a lot. And even during the COVID-19 pandemic, we were able to bring together one another to support one another because people were shying away from visiting our facilities due to fear of COVID. So we improvised and we ensured that we are taking medication to the community members, and we are supporting adherence. And those ones that were due to do sputum tests, we were supporting them and collecting their samples, taking them to facilities, and also reverting the results. We were able to work closely with partners in the country, like Stop TB Partnership Kenya, Water Youth Development, as well as Kelin, that were also supporting us with a little bit of nutrition commodities that we were able to give our clients to ensure that nobody has distracted their treatment. And that worked very well because we were able to reverse the challenges that were happening. And also we were able to reduce the chances of people adhering to treatment, keeping in mind that majority of our clients are also TB HIV co-infected. From my experience being a man, I think the journey has been long, and challenges that we all know that as men, we visit facilities as the last result. Before a man comes to a hospital, they have visited different chemists whereby they just want quick, like microwave services. Just come in, get whatever painkillers and go home. As we know that in majority of our facilities in the country and around the world, they operate morning at 8 to 4 or 5 over weekdays. And the majority of our men who are most affected by tuberculosis, if you look at the data, we have more men that are infected and affected by tuberculosis than women. And so men are the people that do casual laborers. There are people that do mining. There are people that are in transport industries. We are the people that are working in heavy duty, and our work takes a lot of time. That means we don't have even time to come for health facility. So we urgently need gender sensitivity intervention that recognizes the needs of, especially in settings where men are able to come to facilities. We need innovative ways whereby we can reach out to men. Men are available, but let's reach out to them. Let's coil out our intervention to ensure that they are men friendly, and also ensuring that we are bringing on board things like youth friendly services, because people that are affected with TB are mostly young people. And these are very productive people. When a nation has productive people that have gone down due to tuberculosis, then we are losing a task force in the country. So it's high time that as world leaders, as implementers, as donors, we think about funding interventions that are directly going to young people and going to interventions that target and reach out to men, because men are there, men are willing, but the interventions are not reaching out to most of them. Finally, I would like to talk about prevention. It's high time we think about how we are doing prevention, because men are carriers of tuberculosis. We as men, we are the people that work. And when we come in the household, we bring TB in the house and we infect our families. So if we can put more resources toward prevention and targeting men, then we will have done well. Also, in the spirit of multisectoral engagement, we need to bring people on board. We need to have strong workplace policies that bring on board institutions that can screen people from where they are, screen men from where they are in those mining, in those transport industry. We need men to be screened there, to be provided with TB treatment there, so that we are able to reduce the chances of infecting others. National programs, I think they should engage TB survivors, and also they should look at how we bring men survivors to share. We as men, at some point, it is very hard for us to share our health issues with other people that are not are the same gender like us. So we tend to fear, or we tend to just give not all information to our healthcare workers that might be female. So it's not about competition, but it's about coiling and bringing in innovative way that can reach out to men, where we can give men free spaces, whereby men can share their issues with TB, they can take treatment, and they can adhere treatment. Also, youth initiative should be funded, and I recommend all countries to start. If a country has not started, time is now, time is running. It is now. Let us start youth initiative in all countries. Let us invest in young people, because we are the generation that are going to end TB. We know the generation that have passed, they've tried, they've done a lot, they've reached at some point. But this is the generation that is going to end TB. Let us use all resources that we have and invest in young people to ensure that we are finding people with TB, we are supporting people with TB, and we are ending TB. Let's find TB together. Let's end TB together. Nothing for us without us. Thank you.
Thank you so much, Stephen. Very inspiring remarks. Thank you for sharing your story and for basing your calls to action on your experience, your personal experience, also on the experience of the work that you've done in the community. It's really inspiring to hear about that, and also how you catalyzed the work that you started for TB also during the COVID-19 pandemic. Indeed, we are seeing this more and more, that, how the resources built up for TB have really helped not just COVID, but other diseases as well. So as we talk about universal health coverage and universal access to care, TB does play a major role. So thank you for sharing your perspectives and also highlighting the important role that young people can play. Indeed, they are a major player if we want an out-of-the-box response and we want to end TB. Thank you for that, Stephen. So we'd now like to move to Ibu Tiara. We have with us Dr. Tiara Bakasi. She is the National Tuberculosis Program Manager from Indonesia. Ibu Tiara, thank you for joining us. I know it's really late for you, so we are really appreciative that you are connected, and we'd very much like to hear now from a country perspective, the work, the interventions, the responses to make sure that efforts to end TB are as gender sensitive as possible. So over to you, Ibu Tiara.
Okay, thank you, Monica. Good evening from Indonesia. I'm not in Jakarta at the moment. I'm at the eastern part, so it's even later here. Yeah, I'm in Central Sulawesi at the moment, but I'm happy to be with you, and thank you for having me. So I think I will talk a little bit. I'm sharing about the comorbidities in tuberculosis in Indonesia, how we tackle it, and also from the perspective of CRG as well in this important event. Yeah, thank you also, Stephen, for your wonderful speech just now. So for this, I think this is the outline of my presentation, talking about the National TB Target and Roadmap, also the Indonesia comorbidities cases and CRG and comorbidity strategy. First, I would like to start with our national strategy that is already incorporated in our presidential decree on tuberculosis control, and also it is our national strategic plan 2020 to 2024. But since it's already in our presidential decree, so it will go up to our elimination target year, yeah, 2030. So here is the sixth strategy that we have. Of course, for the first one, we're talking about the commitment, leadership, ownership at all at national and also sub-national level. We're talking about the second one, increasing access to high quality and patient-centered tuberculosis, the diagnosis and treatment services. Third one is talking about the promotion and prevention efforts, yeah, provision of TPT as also the infection control. The fourth one is how we utilize the research findings of technologies for screening, diagnosis, and management for the management of tuberculosis. And I think really important for our context today is increase our fifth strategy, increasing communities, partners, yeah, multi-partners, multi-stakeholders, multi-sectoral engagement and participation in TB elimination efforts. And the sixth one is strengthening our program management through health system strengthening as a whole. Here is our TB elimination roadmap. Yeah, even though we have some challenges, yeah, especially after the disruption of COVID-19 pandemics, but we are still optimistic that we can catch up, hopefully. So now I will start with how we already identify our comorbidities. Yeah, that is really important to be tackled as well in our aim to ending TB. First, of course, the TB HIV. Second one is TB with diabetes mellitus, and also here is the number. And also important is TB and tobacco, because here are some studies, and also from our prevalence survey, it was already a long time ago, but still I think still relevant, that smoking is still part of the highest risk factor in Indonesia for tuberculosis. And I think it is also again in the recent global TB report. Yeah, I still quoted the last year's global TB report, but I think it is also similar. Yeah, the result relationship between TB and smoking behavior amongst Indonesian TB patients. So tobacco use is one of our main risk factors. So here are the numbers of TB cases, yeah, male and female. I think in Indonesia we don't really have, difference, yeah, between the male and female patients. I think both have same opportunities. maybe the risks are higher in male. And here is for the treatment outcome. Maybe here we can see that for mortality higher in the male and also loss to follow up. Yeah, maybe this is related also with the the socio-cultural also, and also the status of our men in Indonesia. They are the breadwinner. They are the head of the family. So maybe sometimes it is they don't complete the treatment with relation with those situation. And here is for the treatment outcome also for both sexes. And we continue with the CRG and comorbidity strategy. So for the CRG related interventions, we at the Ministry of Health, not only in NTP, we already have some CRG centralized trainings, and also with regards to TB, I think first we give support the efforts of National Tuberculosis Program in overcoming service quality challenges, providing community feedback on the quality of our services at the health facilities. And the second one is a strengthened response to health and community services with regard to eliminating stigma and discrimination at all levels. And the third is providing data on barriers to access of tuberculosis services that we can use, or all stakeholders can use at all levels of governments, as evidence to identify alternative solutions. And of course, we also create a friendly environment for patients to achieve successful treatment. We still have challenges, but we do our best to provide this friendly environment. So for some interventions, with regard to comorbidities and risk factors, we have maybe the three main activities. Number one is expansion of active case finding, through screening, utilizing X-ray as well, symptom and X-ray amongst the people with diabetic. It is not yet nationwide, but in some high burden areas. And also, of course, for the TB HIV, we optimizing HIV and TB screening. TB patients are tested for HIV, and people living with HIV are screened for TB, both in our CST and DOTS services, because not all CST and DOTS services are under one roof at the moment. The third one is still pretty new, but we also try to do smoking cessation intervention for the tuberculosis patients, in collaboration with our colleagues at the NCD and also with partner or the union, using the ABC approach to smoking cessation guide. And we ask question, brief suggestion, and also fast cessation support. And we start this at the Puskesmas and also some hospitals for this smoking cessations for TB patients. I think that's the end of my slides. Thank you once again for your kind attention, and over to you, Monica.
Thank you so much, Ibu Tiara. Excellent presentation, and you've really, I think, shown us the stark differences, and you've really underlined how important it is that we should be taking into consideration both looking from the lens of comorbidities, because that affects on one end, and also gender. It was quite stark to see the impact on mortality, the difference between men and women, the loss to follow-up. It's such it's a big impact there. Just looking at that makes you see what steps there really needs to be many steps put in place to close those sort of gaps, to make sure no one is lost to follow up. And these are the people who, these are the numbers, the people behind the numbers that we're talking about. So thank you for sharing your perspective and staying so late and joining us at this event. Very much appreciated. Thank you, Tiara. So now we'll take a moment now so we have over 50 participants joining us from around the world. And what we'd like to do, we'd also like to, we want to keep this webinar as interactive as possible. So we'd like to see who is connected. So so what we'd like to do is we'll go on Slido. This is an app that we have. If you've joined NTB webinars in the past, WHO NTB webinars in the past, you're probably used to it. But what we'd like you to do is, and my colleague will share the screen just now, is go on www.slido.com and you can put in the password #men_2022. So either you can type this out or you can use your phone like I'm doing just now, and you can scan the QR code with your phone camera, and it will take you directly to Slido, and you'll come to this poll where you can add in your name and your country. So we'd like to know where you are joining from and your name. So we get an opportunity to know you as well. So I've just posted mine, Monica from Switzerland. Anna is also, who's sitting right next to me on my left. And on my right, I have Wong Yi. So yeah, we're all connected here from Geneva, Switzerland. Okay, we see Kerry Millington from the UK, Philippe Jacon from France. Okay, Ibu Tiara from Indonesia. We have colleagues from Nepal, Tumaini Molenga. We have colleagues from Germany, Zimbabwe, UK. So it's really nice to see people, views from Turkey. It's nice to see all the people joining from around the world, Malawi, Belgium, Canada. So great mix of people. We'll keep this open. And I can see around 20 people have signed in. Please continue to post and introduce yourself. We're really pleased that you've joined us and you're listening in. We have a great lineup continuing. So now what we'd also like you to do, especially now during the panel discussion, my colleague will show you the Q&A. You can stay on Slido, and there is a Q&A tab that you can post your questions on. So if you have a question for any of our panelists, please just type your question, and we will have time during the Q&A session to take any questions that you post. We'd appreciate it if you could also write your name next to the question. So if we have the time and the opportunity, we may call upon you to ask the question in person. So if you could kindly put in your name and your question next to the Q&A tab, that would be great. So it's the same, slido.com, #men_2022, or use your phone camera to scan the QR code. So without further ado, let's move on. And next up, after that very inspiring opening session where you've heard from our WHO director, you've heard from Stephen, who's a TB survivor, and you've heard the country perspective from Ibu Tiara, we'd now like to go into a panel discussion. The panel focuses on a multi-sectoral response on how do you engage across sectors to improve gender equity in TB care. We're very pleased to first introduce the panel, and maybe we'll spotlight each panelist. We have with us Dr. Alastair Story from Find and Treat. We have Timothy Wafula from Kellen. We have Dr. Catherine Houghton from LSHTM, Peter Ngola from TB Proof. So these are our panelists, and so we'll go into a panel discussion right now, and we'd like, thank you so much for joining us, and we'd like you to post your questions so that we can take these during the Q&A part of today's webinar. So to start with, I'd like to call on Dr. Alistair Story. He leads, he's clinical lead of the London Find and Treat service. Alistair, we'd love to hear your perspectives, especially from a multi-sectoral point of view on, the issue of homelessness and ending TB and the work that you are doing in London, especially to tackle this important issue. So over to you, Alistair.
Thank you very much. Thank you for the opportunity, colleagues. It's so nice to see many of you again, and hello to all the new faces. I lead a service called Find and Treat, which is one of those rare initiatives that actually does what it says on the tin. And we have been outreaching diagnostics using digital radiology, GeneXpert, for almost 2 decades now in London. And I think it would be fair to say that the service that we run, it targets people who would really struggle to access the normal routine diagnostic services, which are mainly hospital-based. And the services that we run target people who have the highest rates of TB in the country, and unfortunately some of the poorest treatment outcomes. And those people are likely to be experiencing homelessness. They've been through the criminal justice system. Many have struggled with drug and alcohol problems and mental health problems. And for the majority, they have multiple other comorbidities, including bloodborne viruses and chronic obstructive airways disease, etc. So in the populations that we serve across London, over 80% are male. And that is, for many reasons, probably too long and complex to go into for the purposes of this Q&A. But I think that is an issue that's relevant internationally in terms of the overrepresentation of men in inclusion health populations. And the consequences of that from a tuberculosis prevention and control perspective are quite serious, because many find themselves in an environment where they're sharing a communal airspace with many, many other people. And that these environments are highly conducive to transmission. And now our first speaker, Stephen, summed it up beautifully by basically saying that, men are willing if we reach out to them. And consequently, I think the message I can bring to the table here is, again, just to reinforce the importance of taking services to people, the importance of trying to break down all that stigma related to tuberculosis and enable people to have the opportunity of an early diagnosis. And then perhaps most importantly, the opportunity to get support to complete that treatment. And from the perspective of our service, we're trying to reframe that concept of cure to encompass better housing opportunities, support with addiction, support with a range of other health problems. So, it should be a journey that takes people to a better place. And, I can say hand on heart for many of the people that we've served over the years, the diagnosis of tuberculosis has actually been a good news story. So this is the context of my contribution. It's active case finding for those people who are most vulnerable in society on the streets. And unfortunately, those people are way, way more likely to be men, and consequently come with, again, as Stephen said, all those other challenges of perhaps not prioritizing their healthcare, and for many, not really recognizing the clinical onset and symptoms of the disease itself. Thank you.
Thank you so much, Alistair, for sharing your experience and also for highlighting this important issue of homelessness, how it affects men more, and the need for interventions targeted at this, and of course the linkages with other issues. And it's important also from the context of UK being what we consider a low incidence setting, but there are these pockets of extreme high incidence where we need to really, where targeted interventions such as yours are needed. So it's the same, I guess, in the US and New York and other settings which are typically considered low incidence, but with these big pockets needing care. So thank you for sharing your experience and bringing the spotlight to this issue. We'd now like to turn to Timothy Wafula. He is a health and human rights lawyer and the program manager for health and governance at Kellen. Timothy, we'd very much like to hear from you on your experience from Kenya. I understand that you've undertaken a TB gender assessment, so it would be good to hear your perspectives on engaging across sectors for to improve gender equity in TB care. So over to you, Timothy.
Okay, and hear me well. So yes, I think thank you for giving us the opportunity to be able to just share our perspective. Sorry for the connection. I hope I come clear now. So I think as has been indicated by other speakers, in order to eliminate the TB, we understand, yes, that indeed TB response must address the gender-related barriers to accessing services. So Kellen, with support from Stop TB, did lead in conducting CRG assessment specifically aimed at assessing the gender-related barriers and solutions to assessing TB services that being prevention, diagnosis, treatment care, and support. And also the aim being that this assessment will be able to inform policies and the legal framework to ensure that the policies that are in place, the law that is in place is actually gender responsive and that there are gender specific intervention. So quickly, one thing that we did pick from the assessment, just one finding that I wanted to focus on was just that finding around that the labor work the labor workforce, for instance, in Kenya being largely informal, and that getting off work to go to a health facility would be was something that was highlighted to be a big challenge for casual laborers who are usually paid per day. So somebody feeling that they have to go to a facility, that they'll miss a full day of work and they'll not get the wages for that particular day. And something that was coming out clearly was that majority of these casual laborers who operate in this particular way were identified to be men. And now that being relevant to the conversation that we are having today, as just noting that presenting a barrier to men accessing services. So, for instance, there was that finding that a majority of the casual laborers working in mines, in the fishing industry, in the private-owned public transportation system, being male, and lack that kind of freedom and permission to leave their casual their places of casual employment to seek health interventions without losing money. So something that in response to this, again, something that really came out from the assessment was that some of the regions or the counties in Kenya were actually now started implementing targeted workplace, started targeting workplaces where men would predominantly work, such as these sectors, the quarries, matatu industry, the boda industry, and to ensure that screening is actually taking place at that particular area. And also just given that in some of the places, for instance, the quarries or the mining areas, that there was a challenge with the men leaving to go to health facilities, some of the counties would actually send clinicians or laboratory technicians or a nurse to such sites to conduct TB screening and testing and just be able to refer people. One thing that I want to maybe as I conclude on this is just that some of the interventions that really need to come out to ensure that there's addressing the barriers that actually affect men is first to be able to understand which sectors are we supposed to target. So these either through the assessments that are conducted in countries. So in different countries, the sectors would be different. So for instance, in Kenya, we will find very diverse sectors that the men will predominantly be and that will need to be targeted. So having that initial mapping, that initial understanding of the sectors, who is in the sector, who are the key players. So for instance, if it's in employment setting, are we also ensuring that the employers are engaged? Do we have relevant unions engaged, and who are the people? And I think I just wanted to also echo something that Steve did mention around innovative approaches. So how do you engage, innovatively approach each of these sectors? So maybe how we'll be able to approach people in the mining sector might be different from those in the public transportation sector, but then that being important. But most importantly is, and lastly, is now just understanding in all these sectors, is there an issue that is legal or policy or potentially policy related that needs to actually be addressed to ensure that barrier is addressed. So for instance, if it's an issue of casual employment and the fear of losing the daily wage, is that an issue that can be addressed through a policy to be able to protect and provide an environment that does not act as a hindrance or as a barrier to men accessing services, or to those people who are actually working in such sectors accessing services. So thank you, and I think we'll continue happy with the conversation. Back to you.
Thank you so much for that, Timothy, for sharing, of course, what the barriers are based on your assessment. Indeed, very relevant as you plan interventions, and also highlighting what the solutions have been in Kenya. And yes, as you echoed what Stephen said as well about looking at which sectors and which strategies. So these assessments are really important. Thank you for sharing with us. I'd now like to turn to Dr. Catherine Horton from the Department of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine. She has also been leading or coordinating the organization of this webinar. We're very pleased to have Catherine with us. Excuse me. Catherine and her team have been undertaking several studies to evaluate community and health systems-based interventions to improve men's access to care. So, Catherine, it would be great if you could share with us some of the early outcomes of your studies, and also on why we need to engage across these sectors as we are looking to build a more gender-sensitive, gender-equitable response. Over to you, Catherine.
Great, thanks, Monica. Good afternoon, everyone, or morning or evening, wherever you may be. And yes, thank you, Monica, for inviting me to join this panel. Monica mentioned that I'm part of several research programs. One of these that I'm delighted and privileged to be part of is a 6-year cross-disciplinary global health research program called the LIGHT Consortium. Funded by UKAID, this is a partnership of 7 institutions in 5 countries that aims to generate new evidence on gender and TB. And so I'm particularly interested in thinking about ways that we improve gender equity when it comes to TB. Today, I'm going to speak a bit on comorbidities. So last month, the WHO published a framework for collaborative action on tuberculosis and comorbidities, which recognizes that addressing health-related risk factors and comorbidities among people with TB is an essential component to end TB. The framework calls for people-centered actions to find, treat, and prevent TB among people with key health-related risk factors, but also to find, treat, and prevent comorbidities among people with TB. This collaborative work is essential, given the prevalence and the implications of multimorbidities. But today, as we focus on gender equity, I would emphasize the importance of mainstreaming gender across any actions that we take to address comorbidities. So let's take a moment to look at the risk factors and comorbidities highlighted in this framework through a gendered lens. Because I'm a quantitative researcher, I like numbers, so let me share a few numbers with you. First, looking at behavioral risk factors that are highlighted in this framework. The prevalence of tobacco smoking, which doubles the risk of developing TB and is also associated with poor outcomes, is 5.5 times higher among men than women. Alcohol use disorders, which triple the risk of TB disease and double the risk of poor outcomes, are 8 times higher among men than women. And the prevalence of drug use disorders, which also increase TB morbidity and mortality, are estimated to be 4 times higher among men than women. And now consider the comorbidities. If we look at chronic respiratory diseases like silicosis, asthma, COPD, lung cancer, and also at co-infections such as COVID-19 and viral hepatitis, all result in disproportionately high numbers of deaths among men worldwide. HIV is considered the strongest individual risk factor for TB, and it's a bit more complex. Most adults living with HIV are women, but most new HIV infections are now among men, and those men are less likely than women to benefit from the protections offered by antiretroviral treatment. There's a few remaining risk factors that are mentioned in this framework and that are important, such as mental disorders, diabetes, undernutrition. But I won't go into much detail on these because they're less obviously gendered at a global level. Though, of course, all these factors need to be examined within local context. These health-related risks and comorbidities present an opportunity to step outside the TB silo and engage across the health sector with other programs that are already in place. The LIGHT team at Makerere Lung Institute in Uganda are leading research to develop health facility-based interventions aimed at ensuring gender equitable access to TB diagnosis and treatment by integrating TB screening into existing programs. These may be informed by evidence, for example, from HIV programs that have reached out to men through male-targeted programs like voluntary male medical circumcision, or as partners in antenatal care programs. There's also opportunity for multi-sectoral engagement through tobacco cessation or drug or alcohol treatment programs like those already referenced by Ibu Tiara. But this is only one piece of the puzzle. There's a challenge in thinking that we can reach underserved populations, underserved men, by only engaging at health facilities, because we know that in general, men are less likely than women to engage in health prevention and health promotion activities, and that they delay care seeking, not only for TB, but for any number of afflictions, including many of the key comorbidities we're discussing today. So I think providing integrated care at a community level will also be key to finding, treating, and preventing TB and its comorbidities. To that end, the LIGHT team at Zankli Research Center in Nigeria is developing community-based strategies. Their work builds on a growing body of evidence showing the potential benefits of stepping outside health facilities to improve men's access to TB care, whether that be outreach and screening in occupational settings, as has been done among moto drivers in Nigeria, fishermen in Uganda, or miners in South Africa. Establishing screening opportunities at transport terminals, as has been shown effective in Peru and South Africa, or anywhere else where men are, as has been done in India and as has already been described and emphasized by Al today. The gender differences in health-related risk factors and comorbidities are reflected in the gender differences in TB and vice versa. If we consider why these exist, we see a whole host of social and structural determinants, which are wrapped up in the general socioeconomic, cultural, environmental conditions. But what I think is particularly important for our discussion today, these are also wrapped up in gender norms and expectations. And those permeate all these different levels of influence, whether it be individual, social, community, structural. So I would emphasize that an evidence-informed response to TB and its comorbidities must mainstream gender, with gender-sensitive and gender-specific strategies, or even better, gender-transformative strategies that challenge and work to shift those underlying gender norms that influence so many risk factors for TB and its comorbidities. Thanks very much.
Thank you so much, Catherine, for taking us through all the work that you and your team have done, the Light Consortium have done, the studies, and taking a gendered look at the TB and comorbidities framework. You've also highlighted some really important solutions, what has worked, and really framing our outlook, especially looking ahead at different opportunities for a more multi-sectoral response. So thank you so much for that, Catherine. So I'd like to take this opportunity to again remind everyone, my colleague Wong Yi has posted on the chat the Slido link. Please go on www.slido.com with the password #men_2022, and you can post your questions. We have 2 questions already, one from Aura, one from Pamela. We look forward to you posting some more so that we can have a vibrant discussion during the Q&A session. So you've already heard from 3 of our panelists, and we invite you to keep posting questions so that we can take it during the Q&A session. So now we'd like to turn to Peter Ngola from TB Proof. We're very happy to have Peter here with us, who will speak on the issue around gender and mental health. Peter, thank you for joining us. It would be great to hear about your experiences, particularly your thoughts on engaging with mental health in order to improve men's access to TB care. Over to you, Peter.
Thank you very much, everyone, and good morning, good afternoon, good evening, whatever time it is. I'm happy to be here and share experiences and reflections on TB and mental health. When we look at the slogan that used to be there at the union, the International Union on TB, it mentioned that TB is a disease for the poor. And when we unpack poverty, we are thinking about young people who leave home to go and look for work in the cities, and they're likely to find residence in packed areas where they are vulnerable to TB. When we look at the relationship between TB and HIV, we know that every time somebody has TB, there's anxiety, and it's also a protocol that they have to be tested for TB, for HIV. And all this combined together bring the issue of the status of the psychology of patients when they fall ill with TB. A number of the patients' research and evidence has been brought out that a number of people get into depression, and this depression includes anxiety and alcohol use disorders. We know diagnosis care can happen at the primary healthcare setting, but in most cases, the primary healthcare settings are not equipped enough to handle the mental health of patients. The primary healthcare are mainly at level 2, because level 1 is community. At level 2 is dispensary, where the patients come to collect their drug. So they are not able to diagnose and handle the comorbidities that are associated, like the mental health issues. it's also important to mention at this point that if we look at our strategies, it caters for the issues of mental health. If you look at Pillar 1 in the NTB strategy for NTB strategy, it talks about integrated patient-centered TB care and prevention that includes management of comorbidities, and that is where the mental health falls. If you look at the Pillar 2, it talks about bold policies and supportive systems that incorporate social protection, poverty alleviation, and action of other determinants. That again emphasizes the need to look at the mental health as part of the other determinants. If we look at the Pillar 3, it talks about intensified research on implementation of services and innovations on service deliveries. And service delivery includes service delivery of other enablers or other conditions that bring in the issue of mental health. When we look at the issue of treatment and mental health in TB, we are made to understand that drugs like cycloserine causes psychosis. It causes mental issues. When we look at rifampicin, rifampicin, which is one also of the major treatment drugs in TB, it decreases the effect of and is antagonistic to the TB drugs because it is antipsychotic drug. So we see the interaction between mental health and quality care for TB people, especially in men. What are those things that are we talk about when we talk about depression in men? It's expressed in terms of sadness. It's expressed of loss of interest or pleasure. It's reflected in the feeling of guilt and self-worth. It is reflected in the disturbed sleep or appetite. It's a feeling of tiredness or poor concentration. And we know these are things that we experience every day, that if we are only to provide the anti-TB drugs and we don't address, then we expect that the cure rate might be lower if they are not handled. We also have evidence on the prevalence of mental health. Switzerland et al. Noticed that there is quite a range of depression in both sexes, or both men and women. We find it's it ranges between 11.3 to 80%, with a mean of 48 depression for all the sample that was taken. It also varies. Pachi et al. Found it's between 46 and 72, and Duco et al. Found that the females were at 45 and 51.3 for male. These are clients that were on treatment on TB. In some areas, the range is even very high, particularly for the MDR patient. It was found at 52.3 of the patients were depressed as they were taking their drugs. So the effect of mental health could cause non-adherence. It could cause lower treatment success rates. It could cause lower survival. It could cause loss to follow-up, and at most, it can cause death. And as we celebrate the Men's Day, we are urging for mental health to be considered as part of the care for all patients, particularly for men, as has been mentioned by my colleagues, that men's pathway to care is normally not very good. They take longer time to go for care, and they are less adherent to care because they are not used to medication. We also look at the individualized treatment, so that all people who come for care are not treated equally. We look at each patient under the counseling and see if they are undergoing any depression or any mental health issues, so that we have what we describe in the TB as quality of care other than care only. Thank you very much.
Thank you so much, Peter, for your very passionate intervention, for connecting all the dots across the three pillars of the NTB strategy and highlighting how important how important mental health issues are and its linkages to ending TB. This is indeed an area where we are increasingly putting the spotlight on, but there definitely are more efforts needed to address this issue of mental health, the impact also of medications, as you rightly pointed out, and addressing issues around depression and other mental health linkages. Thank you very much for sharing, Peter. So with this, we come to the close of our panel discussion. If we could spotlight all the panelists again. So it's really, thank you very much. Thank you, Alistair, Catherine, Timothy, and Peter for your various interventions. I see that there are a few questions on the chat, and Aura, I don't know who Aura, Eunice Aura, has a question. So I'm going to promote you, Eunice. You have a question, I believe, for Alistair about loss to follow up. So we'll take a tiny pause here to have a bit of a Q&A. So Eunice, would you like to take the floor? Eunice? Okay, if not, maybe I can read out her question. So this question was addressed, I guess it came when Alistair, you were presenting. And the question is, how do we reduce loss to follow up on our homeless patient street family? Also the adherence, because this is where we have poor outcomes. So Al, it would be appreciated if you could share your perspectives. If there are other panelists who would like to jump in and add based on the work that you're doing, please feel free to do so. So first we turn to you, Alistair.
Thank you very much for the question. It's a very important one. I mean, unfortunately, we see the highest rates of TB globally in those people who are, the poorest in our society, the most marginalized. And amongst those same groups, we see the worst outcomes. Now, we've learned the hard way in terms of, we originally set up a service that was just a case finding service, and we delivered people to hospitals to have the diagnosis confirmed. They had a normal radiology and symptoms, and 53% were lost. This is many years ago, before the confirmation of the diagnosis. So I think a very important lesson for us very early on was to think that, the need for support actually starts with a high index of suspicion for TB rather than just the confirmation of the diagnosis. People are very good at triaging themselves out of the system and disappearing prior to the confirmation of TB and prior to the initiation of treatment. So for us, support starts, from first encounter. And in terms of the reasons why that's important, I think it's necessary to recognize that internationally, the people who are most vulnerable have a lot of other needs. They have a lot of competing priorities. They search for food. They need safety. They very often have struggling with addiction. But I think most importantly of all, they've been let down, and there's a challenge to get trust, and trust is the golden ticket to a good TB treatment outcome. And one of the things that I couldn't emphasize enough in terms of being able to engage with people and build that trust is you know, we're immensely fortunate to be able to work alongside people who've been there, seen it and done it. People who've got lived experience of not only TB, but of being on the street and struggling with addiction, being excluded from services. And people with lived experience are the key. They're the magic ingredient that makes our outreach service work, because they have, you know, they've acquired a very dangerous qualification, and that qualification is to know how to survive and to know how to engage with people and to build that magic ingredient, which is trust. If we've got trust, if we've got good engagement, we can get good outcomes. But outcomes in terms of adherence and preventing people from, you know, being failed by care is all about providing a service that's relevant to their needs, and it has to go way beyond just providing pills. It has to, as this conversation has referenced on many occasions, it has to be multi-sectoral. It has to try and support people to access the housing that they deserve, support people to access any kind of social benefits they would deserve, support people to re-engage with community and family, support people to address mental health problems, addiction, etc. So the care needs to be relevant to what people see as being their needs. It needs to go way beyond just trying to kill Mycobacterium TB. It needs to extend to, you know, the very real challenges that people face. And when we do that, we achieve as good outcomes in the people that we serve as is achieved by general services for the general population in this country, in the UK. But we have to have some tricks up our sleeve, and it extends all the way from small incentives to using non-clinical workers in the community to support people to take their treatment, multiple digital interventions, and for those who are most vulnerable on the street, we actually run a TB respite hostel for people who would otherwise be excluded from accessing any kind of housing in this country, and they live there for the full duration of their treatment, food, boarding, love and hugs, and most in fact move either back into the labour market or reconnect with family and friends elsewhere. So it's a journey, and it's way more than pills.
Thank you so much, Alistair. I mean, you have this experience right from the ground, and indeed, as you highlighted, it's not just a medical issue. It's much beyond looking across, building trust, engaging with other sectors. Thank you for sharing. And I think you've also addressed the question posed by Pamela about how, well, it says, how do we deal with those not adhering to treatment? But it's more about how do we make sure that we do not fail the provision of care, making sure through all means necessary to make sure that access to care is enabled. And I think you have shared this very clearly about what has worked. I see that Stephen would like to add something. Stephen, from your experience, would you like to add as well?
Yeah, thank you very much, Monica, and thank you very much, our colleagues, for asking that wonderful question, and Alistair has answered it. I think it's all about investing. If you think about the treatment that we provide to people, it costs us as much as we can. So I think it's all about programs and the world coming together and ensuring that we provide supplement, things like nutrition support, because the people that are not adhering to treatment, if you follow very well, close to 80% of them are not adhering because of challenges of nutrition. So if we can invest in providing food basket to those that are on treatment and are on streets, because they go on streets to look for food. So if you can provide and initiate them and entice them to ensure that they are well catered for, they are able to get medication as well as food support, then they will be able to adhere to treatment, and we will reduce the issues of having people interrupting because of homelessness. The other thing about homelessness, the people that are street family, the ones that don't have homes, I think in the UK, they have wonderful structures. In other countries like here in Kenya, I think it's high time we rethink about that, because they're also citizens. When it comes to things like voting, they also vote. And if somebody has the ability to vote, then that person is very important in the country. So it's all about initiating things like social protection, initiating things like social protection for everybody that is in the country, and those, especially those that are vulnerable because of the health condition like TB. Thank you.
Thank you very much, Stephen. Indeed, anti-nutrition and TB have big linkages. And as you've rightly pointed out, food baskets could be an incentive that would work. And also, I think Timothy touched upon the various barriers, work-related barriers as well, access to food, so many different elements when it comes to adherence to treatment, both looking at homelessness and beyond. Peter, you have your hand up. Would you like to add as well?
Yeah, thank you. I just want to add one thing all above what Steve had already said, that here again, we need the public-private partnership. We know wherever there is conferences or meetings, there's a lot of food that is normally thrown out to the pigs. And here we can have a partnership where we have hotels that feed the street children, so that, and the incentive would be that you take your drugs, I give you food to, or I give you food and you take your drugs, to help the partnership in adherence to that challenges. Thank you.
Thank you very much, Peter. Indeed, many ideas that could be leveraged, depends on the country's setting and context. So we'll take a pause here again. If you do have questions, please do post on Slido. I see a question from Vittal Prasad Mainidu about how do you manage cross-border migration or with refugees who have TB, drug-resistant TB or TB-HIV. It's a very valid question, but and we'll post on the chat for you an interagency field guide that WHO has developed with UNHCR and CDC, which outlines clear guidance on this topic of migration and the refugee crisis and TB, and we'll come to that topic. I think that's a topic of a whole other webinar that we can focus on. So thank you for that question, but please keep your questions coming. We'll come back to this panel again, but we'll take a pause here, and we'll now turn to Dr. Grania Brigden, who has joined us from the Global Fund. Grania, thank you very much for being here with us. Grania will talk to us about investing to ensure no one is left behind, on how we can ensure that investments and resources and allocations can examine and mainstream gender. So Grania, over to you now. Look forward to hearing from you. Over to you, Grania.
Thank you, Monica, and thank you, everyone. And I would actually really like to thank the panelists, because they have set up and covered a lot of the sort of background that I hope now, and to Stephen's point around the need to invest in a gendered approach to TB care. So today I'm going to just give a sort of slight overview about gender at the Global Fund, and really it's key to all of our work. And I think really it's understanding that there are gender-based barriers to care that exist, and as you've heard so very clearly from our panelists, around sort of the challenges that men with or at risk of TB have with regards to accessing care, and how that cascades down to poorer outcomes and harder to find and treat and prevent TB. And so it's really what the Global Fund would like to do and wants to do, is work with countries and country programs to really establish what these gender barriers are and support programs to really becoming sort of gender responsive, and getting the information with regards to age and sex, the aggravation of, to find out where the gaps are, and then work to implement models of care that can help overcome these barriers and ensure that everyone, regardless of your gender, is able to access care. And I think what has been sort of very clearly highlighted, particularly from sort of Tiara and others, is that gender doesn't exist in a silo. It's very intricately linked with issues with human rights, community systems, community engagement, and within particular key populations and at-risk behaviour. So it was great to see that highlighted by the panelists earlier. All right. So, as I said, gender is key to the Global Fund and will continue to be key. So in the new strategy that's starting in 2023, sort of gender is a key part in the sort of design, delivery and evaluation of all of our programs. And there's a gender equity focus across the portfolio as we go for the ultimate goal of ending AIDS, TB and malaria. And it's really looking at that people-centered integrated systems, maximizing engagement and maximizing health equity, gender equity and human rights. So that is how sort of going forward on the broader level for Global Fund, how gender is part of our work going forward. But also it's key to the TB specific sub-objectives in the new strategy. And so as you can see here, really putting equity and people-centered approaches when we think about how we find and treat all people with TB, and then make sure that we're offering them on TB prevention, high quality of TB services, and ensuring that they get the new tools and guidelines as they become available. But also, and cross-cutting all of the kind of maybe more technical approaches, is the enabling environment. And this is where sort of working in collaboration with partners and affected communities is key to identify and reduce the gender-related barriers and how those may interlink with human rights issues, gender discrimination issues, and stigma-related issues. So it really is key to going forward. And as of next year, we've had a successful successful replenishment conference. So we are hoping that when we want to work with countries to continue to build the support in the next funding round, which the application process starts next year. And so I'll focus a little bit of time on how countries and partners working within the CCM mechanism within countries can ensure and put a gender equitable response into the funding request. So the TB information note is available on the website, is available in English, French and Spanish. And as you can see there, it kind of highlights the various interventions that Global Fund could and can support. And as you can see there is this dedicated section on equity, human rights and gender related barriers. And I think maybe to the point on the light work is kind of just, these are some of the gender responsive and gender transformational interventions that Global Fund has supported in the past. But we are, as the research and implementation in this area expands and more successful programs are implemented, then we hope that these can be used to either scale up in country or be shared so that they can be utilized and adapted by other countries. But as you can see here, it's really sort of looking at gender responsive community case finding, and I think Al's work of sort of changing how we find people and looking to sort of see either places of work where men are based or places where women gather, make sure those who are providing care to TB are aware of the impacts on gender, and that case finding algorithms as I think has been said by a number of our speakers, one size does not fit all. And so we do really need to sort of think about how case finding algorithms can be adapted depending on the gender challenges for accessing healthcare, and looking to see around ensuring that the services are available at the times. I think Timothy's point, sort of making the services available when people can, particularly men who may be in employment, can access them and not suffer catastrophic costs. And then also thinking about how the gender transformative interventions are within the workplace as well. So these are some of the ideas, but as I said, really this list can continue to expand and can be supported within the next round of Global Fund grants. But gender does not only come into the funding request process, it is throughout the whole Global Fund grants cycle. So as Tiara mentioned, Global Fund funding requests should be based on NSPs, and she very nicely showed sort of how gender human rights are within, sort of were incorporated within the national strategic plans. So these, and this is where sort of supporting and strengthening NSPs, looking at gender within those processes and developing sort of approaches that address any national gender gaps within the NSP, which can then go on to contribute to the Global Fund funding requests to ensure that they are they address some of the gender barriers. But after the gender funding requests have been approved, then as the grant is being implemented, it's really ensuring that these activities are implemented and that the program continues to be gender responsive in its implementation of TB, case finding and care. And then I think probably another key area is that embedding gender within the M&E. So if you do not know where or how your gender gaps are, then it is very hard to see if you are addressing them. So really the importance of age and sex disaggregation to ensure that you are identifying and addressing any gender inequities that exist. And so with that in mind, the Global Fund does, have in the new modular framework, gender, these are the sort of key areas that any program implementer or principal recipient need to give gender disaggregation. So to really help highlight that where men or women may be being missed within their program. Now there are so these are the ones where it is there is a requirement for the gender disaggregation. In the other indicators, there can be gender disaggregation, and it is often encouraged, but it is not a predetermined requirement. And I think that is also shows the importance of continuing to invest in case-based sort of digital real-time disease surveillance systems, so that the data that you're collecting is accurate and it is as close as real time, so that any changes or gaps can be timely addressed and highlighted any key or vulnerable groups. And so as my colleagues have done such a good job of underlying the kind of challenges, but also I think the importance of thinking of gender throughout all the work we do, and ensuring that, you know, a gendered approach, looking at addressing gender inequities, benefits everyone. And so I would like to thank everyone for your time today. All the information for the new funding request is available on the Global Fund website, and I'm happy to take any questions now. Thank you.
Thank you so much, Grania. Very comprehensive presentation, underlining the importance also that Global Fund places on making sure that all proposals and the work that's being supported is as gender equitable and gender sensitive as possible. As you've rightly pointed out, also, I think it was really important what you flagged about the importance of gender considerations in the monitoring frameworks, because what gets reported tends to get, or what gets asked to be reported tends to get done. And also it helps when donors and funders do this, also because with the investments and support provided and the accountability raised around this through a monitoring framework, there can be impact. So thank you for sharing the Global Fund perspectives. So I'm having a look at Slido and I see that there are no further questions. So I'd like to thank you, Grania, for your input, and also all our panelists. And I'd now like, as we're coming to the end of our session, I'd like to now turn to Dr. Bertie Squire. He is Professor of Clinical Tropical Medicine, Dean of Clinical Sciences and International Public Health at the Liverpool School of Tropical Medicine. Bertie is also has always championed the issue of addressing TB in men, I think going years back, and it's actually been Bertie's constant push that we've started also spotlighting this issue through these webinars. So thank you, Bertie, for being here, and look forward to hearing from you on your closing remarks. So over to you, Bertie.
Thank you very much, Monica. Thank you, everyone. And I should just mention that although I'm based at the School of Tropical Medicine in Liverpool, I'm currently in Zimbabwe, so the internet connection might not be completely as you would hope, but I'm grateful to be hosted within the Center for Sexual Health and HIV/AIDS Research here in Zimbabwe, just for this. Thank you also, Monica, for mentioning me in relation to championing men. I would like to say that it's really coming from the perspective of the work we've done over many years on poverty and that intersection with poverty and gender, which has really come out in today's remarks. And in a minute, I'm going to return to that word, intersectionality. But first of all, I want to also recognize that the extraordinary power of hearing from both men and women in relation to this really important question of gender and the way in which it interacts with the tuberculosis pandemic. And I think today's panel really represents the way in which this is recognized to be a really broad issue affecting both sexes and across ages. So I'd like to start by just reflecting back on what Teresa said at the beginning about, and my own view, that this session has really created a multisectoral conversation, explored opportunities that there might be through multisectoral engagement, and as I hope, widened understanding of gender inclusivity in the global response to TB. Just that's where we started. And when I think about how that has played out over the course of today, it's really flagged through every presentation and every discussion the way in which male sex and gender intersects with some of these other huge drivers that many people have picked. I don't have time as I look at the clock to go through all of them, but just some that really jumped out for me. So behavior, masculinity and health-seeking behavior, smoking and risk factors, homelessness, comorbidities and the behavioral risks that lie behind them in relation to harmful use of drugs and alcohol, occupation and silicosis, fragile livelihoods and casual labor as flagged by Timothy. And then in the Q&A, nutrition, social protection, the intersection with the private sector, and then ending up with some really important words from the Global Fund around the importance of that promoting and enabling environment that address catastrophic costs due to TB. And finally, continuing to know your epidemic. And I want to end there with just a reminder that most new infections around the world amongst men, women, and children arise because of contact with undetected, untreated men. And I think we need to keep that at the forefront of our efforts as we go forward. So finally, just to end with a huge thanks and special recognition to WHO for putting the spotlight on gender and TB through this second great webinar on marking International Men's Day. Thank you very much, everybody.
Thank you so much, Bertie. Very inspiring closing remarks and a very excellent summary of all the discussions. It's really been important and it really rounds up, I think, our webinar, reminding us of all the discussions. I'd now like to take this opportunity to thank you, Bertie, also to thank our various speakers. Also thanks from our director, Dr. Teresa Kasaeva. Thank you for joining us, Stephen, Ibu Tiara, Dr. Alistair Story, Timothy Wafula, Catherine Horton, Peter Ngola, and Grania Brigden. Thank you for being our speakers today. I'd also like to thank the organizing committee behind this webinar that you see here. It is indeed a joint collaboration between WHO and, as I mentioned up front, the Union Working Group on Gender Equity and TB. And I'd like to, as I said, thanks to Catherine Horton for overall coordination, to Kerry Millington, Amrita Daftari, and Joseph Daniels, as well as my colleagues here at WHO that you see with me, Anna Stikalova and Wong Yi. And I'd also like to thank all of you in the audience. We have over 50 of you joining us. Thank you for your interaction, for your questions, and for making this commemoration of International Men's Day very meaningful and memorable by putting the spotlight on ensuring a multi-sectoral, gender-sensitive, gender-equitable response to ending TB. So thank you all, and have a good rest of the day or good rest of the evening. Thank you, everyone. Goodbye.
Goodbye and thank you.
Goodbye, Monica. Thank you. Thank you, Anna.
Thanks, Monica. Thanks, everyone.
Thank you.